VEGF trap-I, a biologically engineered protein, is under clinical investigation in wet AMD. VEGF trap-I comprises portions of the extracellular ligand binding regions of native VEGF family receptors, namely VEGF receptor 1 and VEGF receptor 2. By fusing the key binding domain from the human VEGF receptor 1 with a key binding domain of human VEGF receptor 2, tight binding affinity for both VEGF-A and PLGF is achieved. Two dual domain arms are then fused with the Fc portion of a human immunoglobulin G antibody, mimicking the natural receptor necessary for high affinity binding of dimers. Therefore, VEGF trap-I binds active dimers with high affinity in a precise 1-to-1 ratio, like two hands clasping a ball. In addition to VEGF-A, VEGF trap-I also binds PLGF. VEGF trap-I binds both growth factors with high affinity, higher than the affinity of these ligands for their natural receptors, as characterized in the literature for VEGF-A 121, VEGF-A 165, and PLGF. Thus, when bound to VEGF trap-I, the VEGF dimers cannot activate their cell surface receptors on the vascular endothelium, thereby inhibiting a key angiogenic signal. Studies are underway to determine the clinical relevance of the pharmacologic properties of intravitreally administered VEGF trap-I, namely the ability of VEGF trap-I to bind both VEGF-A and PLGF with high binding affinity. Regeneron Pharmaceuticals and Bayer, global development partners for VEGF trap-I, are committed to advancing the management of wet AMD to help address patients' and ophthalmologists' unmet medical needs.
Eylea is administered by intravitreal injection. The recommended dose for Eylea is 2 milligrams delivered in 50 microliters of aflibercept. The solution is a clear and colorless to pale yellow isoosmotic solution. Inspect Eylea prior to use. Do not use the vial if particulates, cloudiness or discoloration are visible. The vial is for single use only. Intravitreal injections must be carried out by a qualified physician according to medical standards and applicable guidelines with experience in administering intravitreal injections. Follow the guidelines outlined in the prescriber guide. Adequate anesthesia and a standard aseptic technique must be ensured. It's recommended to use surgical hand disinfection, sterile gloves, a sterile drape, and a sterile eyelid speculum or an equivalent. Use a syringe for applying povidone, a sterile caliper, sterile cotton-tipped applicators, cotton swabs and 4x4 sterile pads, saline solution and povidone iodine. Remove Eylea from the refrigerator. The vial should be refrigerated until just prior to injection. It should never be frozen, exposed to direct sunlight, reused between patients, or used beyond the expiration date. Please note the pack shown is an example. The actual package may differ. A 30-gauge half-inch injection needle for the intravitreal injection should be used. To prepare Eylea for injection, aseptic techniques should be used. Remove the plastic cap and disinfect the outer part of the rubber stopper of the vial. Attach the 18-gauge 5-micron filter needle supplied in the carton to a 1 milliliter sterile Luer lock syringe. Push the filter needle into the center of the vial stopper until the needle is completely inserted into the vial and the tip touches the bottom or bottom edge of the vial. Withdraw all the Eylea vial contents into the syringe, keeping the vial in an upright position, slightly inclined to ease complete withdrawal. To deter the introduction of air, ensure the bevel of the filter needle is submerged into the liquid. Continue to tilt the vial during withdrawal, keeping the bevel of the filter needle submerged in the liquid. Ensure that the plunger rod is drawn sufficiently back when emptying the vial in order to completely empty the filter needle. Remove the filter needle and properly dispose of it. The filter needle must not be used for intravitreal injection. Using aseptic technique, firmly twist a 30-gauge half-inch injection needle to the Luer lock syringe tip. When ready to administer Eylea, remove the plastic needle shield. Hold the syringe with the needle pointing up and check the syringe for bubbles. If there are bubbles, gently tap the syringe with your finger until the bubbles rise to the top. Eliminate all bubbles and expel excess drug by slowly depressing the plunger so that the plunger tip aligns with the line that marks 0.05 milliliter on the syringe. Administer topical anesthesia. Instill disinfectant, for example 5% povidone iodine solution, according to manufacturer's guidance. Consider using a morphine glass dropper. Apply disinfectant, for example 10% povidone iodine solution, to preocular skin, eyelids and eyelashes, avoiding excessive pressure on eyelids. Cover with sterile drape and insert sterile lid speculum. Tell your patient to look away from the injection site. Position the eye externally. An area of 4
شروع کنه؟ نه بابا شروع میشه هفته Hello
vitreous floaters, or eye pain. These conditions normally go away a few days after the injection. Close monitoring of the patient during the week following the injection will allow early treatment if any infection occurs. Your patient should be advised on the frequency of injections within their treatment plan and be fully aware of any need for future appointments. For further information, read the written Eylea prescriber guide.
Our brand has come a long way. And from the very beginning, the Bear Cross has been part of this journey. Today, this logo represents our foundation and stands for one of the best known, most valuable, and most trusted global brands. Our brand attracts the employees that we are looking for. Passionate, curious, and innovative people all around the world. Acting as master brand, the Bear icon creates sustainable value for our product portfolio. And we firmly believe in our mission: science for a better life. We believe in science to develop new molecules and technologies, to drive meaningful innovation, and to improve the quality of people's lives. We believe in life science. We are committed to being open-minded, to exploring, and to never giving up. Understanding, fairness, and trust are at the heart of everything we do. This is how we make a difference in this world, and this is why we are one of the world's leading life science companies. Bayer. Science for a better life.
Eylea is administered by intravitreal injection. The recommended dose for Eylea is 2 milligrams delivered in 50 microliters aflibercept. The solution is a clear and colorless to pale yellow isoosmotic solution. Inspect Eylea prior to use. Do not use the vial if particulates, cloudiness or discoloration are visible. The vial is for single use only. Intravitreal injections must be carried out by a qualified physician according to medical standards and applicable guidelines with experience in administering intravitreal injections. Follow the guidelines outlined in the prescriber guide. Adequate anesthesia and a standard aseptic technique must be ensured. It's recommended to use surgical hand disinfection, sterile gloves, a sterile drape, and a sterile eyelid speculum or an equivalent. Use a syringe for applying povidone, a sterile caliper, sterile cotton-tipped applicators, cotton swabs and 4x4 sterile pads, saline solution and povidone iodine. Remove Eylea from the refrigerator. The vial should be refrigerated until just prior to injection. It should never be frozen, exposed to direct sunlight, reused between patients, or used beyond the expiration date. Please note the pack shown is an example. The actual package may differ. A 30-gauge half-inch injection needle for the intravitreal injection should be used. To prepare Eylea for injection, aseptic techniques should be used. Remove the plastic cap and disinfect the outer part of the rubber stopper of the vial. Attach the 18-gauge 5-micron filter needle supplied in the carton to a 1 milliliter sterile Luer lock syringe. Push the filter needle into the center of the vial stopper until the needle is completely inserted into the vial and the tip touches the bottom or bottom edge of the vial. Withdraw all the Eylea vial contents into the syringe, keeping the vial in an upright position, slightly inclined to ease complete withdrawal. To deter the introduction of air, ensure the bevel of the filter needle is submerged into the liquid. Continue to tilt the vial during withdrawal, keeping the bevel of the filter needle submerged in the liquid. Ensure that the plunger rod is drawn sufficiently back when emptying the vial in order to completely empty the filter needle. Remove the filter needle and properly dispose of it. The filter needle must not be used for intravitreal injection. Using aseptic technique, firmly twist a 30-gauge half-inch injection needle to the Luer lock syringe tip. When ready to administer Eylea, remove the plastic needle shield. Hold the syringe with the needle pointing up and check the syringe for bubbles. If there are bubbles, gently tap the syringe with your finger until the bubbles rise to the top. Eliminate all bubbles and expel excess drug by slowly depressing the plunger so that the plunger tip aligns with the line that marks 0.05 milliliter on the syringe. Administer topical anesthesia. Instill disinfectant, for example 5% povidone iodine solution, according to manufacturer's guidance. Consider using a Moorfields glass dropper. Apply disinfectant, for example 10% povidone iodine solution, to periocular skin, eyelids and eyelashes, avoiding extensive pressure on eyelids. Cover with sterile drape and insert sterile lid speculum. Tell your patient to look away from the injection site. Position the eye adequately. At an area 3.5 to 4 mm posterior to the limbus, mark an injection site. Insert the injection needle into the vitreous cavity, avoiding the horizontal meridian
شروع کنیم؟
بله شروع کنیم.
Okay. Hello everybody. Good morning, good afternoon, and good evening, depending on the where you are. Welcome to this webinar on cataract in difficult situations. We have a galaxy of speakers, experts, speakers, and panelists, and I hope you will enjoy this webinar. I would like to thank all the participants, especially our dearest Indian colleagues who accepted our invitation. Special thanks to Dr. Professor Amar Agarwal, President of IIRSI, and Dr. Mahipal Shachdev, President of All Indian Ophthalmological Society, and of course, my co-moderator, Dr. Priya Narang. And also, I would like to thank all my colleagues at the Iranian Society of Ophthalmology, especially Dr. Mahmoud Jabbarwand, who will say a few words before we start the webinar, and also Dr. Karimian, who is the director of this year meeting, Professor Javadi, who is panelist, and Dr. Jadidi, and also Dr. Siamak Zarei. First of all, I would like to ask Dr. Jabbarwand to say some words. Please, Dr. Jabbarwand.
In the name of God, it's my pleasure to formally start the session of cataract surgery in difficult cases. We are honored to have Professor Agarwal and his colleagues, as well as our Iranian doctors in this session. I thank Intraocular Implant and Refractive Society of India for their kind participation and taking part in our webinars. Dr. Qureshi, please start the session.
Thank you very much, Dr. Jabbarwand. Can I ask Professor Amar Agarwal to some opening words?
Thank you very much. First of all, I would like to thank the whole Iranian society. And I can tell you one thing, the relationship between Iran and India is now become so close. We are such good friends together. It's such a pleasure that IRSI is able to partner now with the Iran society for this lovely webinar, which is going global. And I wish everyone all the best in life.
Thank you very much. Dr. Narang, can you say some words and present the first speaker, please?
At the outset, I would like to thank the Iranian Ophthalmological Society and Dr. Qureshi for passing on such a beautiful invitation to all of us and for holding this webinar in association with Indian Intraocular Implant and Refractive Society. So we have an array of speakers, and I think the first speaker is Dr. Amar Agarwal. He's the chairman of Dr. Agarwal Group of Eye Hospitals and world famous ophthalmologist. So we would request Dr. Amar to please come up with your talk, and he will be talking on glue-dial, PDEC, and single pass orthopupilloplasty in challenging situations.
Thank you very much. I'll just start sharing my screen first. And let me know if the video is seen or not.
Yes, it is. Your screen is seen, but video is not still run.
Is the video coming or not?
No, the video is not coming. We are not seeing the video.
1 minute, there's something wrong somewhere. I'll just start it again. Why is it not showing me?
Mr. Rezai, can you help?
We can see your screen.
I know,
please
but
click on that.
now is it coming or not, the video?
No, we are not seeing the video.
I don't know why I'm not getting it.
Would you play your video?
Yeah, I was playing it just now. I was playing it just now. No?
Not
not playing. We see your screen, but we don't see your
One
video.
second. Again, I'll start again. I'll start sharing screen.
Please open
1
your
minute.
video before start sharing and select, and then select.
One second. I'm playing my video now. Okay, you want me to first play the video? That's what you're saying? Okay.
Yes,
Yeah,
we are
yeah.
seeing.
1 second.
It's gone.
It came now? Now, 1 minute. Share screen. Now is it coming?
Yeah. Yes. Yes.
Yes.
The video is
Yes.
coming now?
Yes. Yes.
Let me know if it's coming full screen or not yet now.
Yeah, it's good.
It's full
Just make
screen
it-
now?
It's okay.
Yeah.
Yeah.
Okay, fine. So I thought I'll just show you this case particularly. If you notice, this is a case of pseudophakic bullous keratopathy with an anterior chamber IOL inside. And look at how badly scarred the cornea is. Now, the first thing what I'm doing is I'm making my scleral flaps. Once I made my scleral flaps, they are 180 degrees apart. I know this IOL has to come out. So before that, I want to clear off this epithelium, which is so badly hypertrophic there, so that I get a slightly better view. I've now fixed my trocar inside the eye there, which has fluid in the eye. And I notice my flaps are not exactly 180 degrees apart. So I made them exactly now 180 degrees apart. I made a 22 gauge sclerotomy and I'm doing a vitrectomy. In such complicated cases, I always check inside because the surgeon might have dropped the nucleus or an IOL inside. I've done a vitrectomy, posterior vitrectomy. Now I make my scleral incision. My next step is to take out this intraocular lens. And you can see I'm removing it slowly, piecemeal. The problem in this is there are 4 haptics that have got locked onto the iris. So one has to be careful, otherwise bleeding can occur. Now, if you notice, I'm removing them very slowly and they're coming out slightly broken. Most of it has been removed, but if you see some haptic is still inside, that's one more haptic coming out. And now there's one last piece which is locked onto the iridectomy there. Again, I'm trying to be careful to remove it so that it does not produce bleeding. But even when I'm doing that, you'll notice slight bleeding has occurred. But touch wood, I've been able to remove that last haptic. Now, once I've done the explantation of the ACIOL, my next step is to do the glued IOL procedure. So I catch the haptic there. Once I've done that, I'll externalize the first haptic. Now I go in and I now flex my second haptic inside the eye. And you can see now I'm catching the haptic tip and bringing it out. So far, so good. Now see the amount of haptic externalized on both sides. See the blue coloration is a lot. That is important because that much amount is haptic is being tucked inside the eye. I make a 26 gauge needle, intrascleral Charriot's pocket, tuck the haptic inside. Now remember, the next step is I need to do a 4-throw pupiloplasty. The reason we do the single pass 4-throw pupiloplasty is 1, it will keep the air in the anterior chamber. 2, any anterior synechia which is there will be broken and any closed angle glaucoma will become open. So very simple way to do is you take a Prolene suture, 10-0, 9-0, whatever you have, go through clear cornea one side. On the other side, I'm passing a paracentesis. Remember, one side there is no paracentesis where the needle is passed. Where the 30 gauge needle passes, you pass a paracentesis. Pass the 30 gauge needle through the paracentesis, through the iris, railroad the two, so the suture comes out. Now bring that loop out. That is single pass. Now remember the number 4, 4 times pass it. And that's all you need to do. That completes the single pass 4-throw pupiloplasty. Simple procedure. You don't need to do 3-2-2 throws or 4-3-1-1. Simple, just once, 4 times. So now watch it. I pass the needle from one end. Now it's going through the 30 gauge needle, bringing it out. Now watch, I'll bring the loop out. I've caught this suture, brought it out through the paracentesis. Now I pass it 4 times through that same loop, and that's all we do. Once you have done that, I've also made the pupil like a pinhole. In other words, if there is any astigmatism which can happen, it gets nullified. So you created a 1.5 to 2 millimeter pupil, and this is a pinhole pupil also I've created. Watch the Purkinje image P1. It is bang in the center of the pupil. So I know my optical center and the pupillary center, or the visual axis and the pupillary center, are both together. That means my angle kappa, or the chord mu, is nearly 0. Now, once I've done that, see my air, it remains inside the eye. Now, we don't do DMEX, we don't do DSEX. The procedure which we do is this procedure called PDEC. The reason is very simple. In DMEC, the donor is about 40 to 50 years and above. In DSEC, the thickness of the donor is too thick, about 80 micron, 100 micron. In PDEC, we can take young donors below 40 and only 25 micron. How do you prepare it? See, this is the endothelium. You're looking at the endothelium. I've taken a 30 gauge needle with air through the sclera, and I'm going to create a bubble. Now, watch the bubble creation. This bubble does not go to the periphery. So that means, where is the air? You have endothelium, you have desmase, then you have got the pre-desmase layer or the Duas layer, then the air, and then the stroma. So this is the PDEC graph. And we have to say, we started this with the help of Harminder Dua and from UK. Now, once you have done that, I stained it with trypan blue, dissected it, and that's my PDEC graph. Once you have the PDEC graph, it works just like a simple DMEC graph, but much better, because it is a young donor, better endothelial cells, and easy manipulation. I use this double infusion cannula technique, where I've got fluid in the back, and in the front I fixed a trocar AC maintainer for air. So you see, now this one gives air in the front. Once I have done that, my next step is I will take off the endothelium. So here you can see I'm taking off that bad diseased endothelium from the eye there. And once that endothelium and desmase is stripped off, you can see the whole thing coming off. Air is continuously being infused into the eye. Now I take my PDEC graft, inject it just like you will inject your DMEC graft. You can use any injector system you want. Check the positioning, check the centration. We always use an endoilluminator to check whether the graft is right side or wrong side. I'm injecting air under the graft, you can see there. Once it's there, I on the air pump on. That trocar AC maintainer is connected to a continuous infusion of air. Now all I can do is I can manipulate that graft. So I never do this tap, 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 dance, dance, dance of a DMEC graft. In PDEC, it's not needed. I can manipulate the graft very easily, unroll it, and you can see the graft in place. I've applied the fibrin glue, sealed everything down. Now the question comes, how did this patient behave? So at the end of it, let's see how this patient looked intraoperatively. This is how it looks. And now let's look at the picture, how it looked post-operatively, and we'll see how the patient behaved. This is the same patient 2 weeks post-op, as you can see. 1 month post-op, patient has improved to 618. Look at the patient 2 months post-op, 6.9. And now you can see the patient 3 months post-op, the vision is already 20/20. And look at the final picture, pre-op, and look at the patient post-op, and you can see the vision is already 20/20. So what did we do? We did explantation of IOL, then we did the glued IOL, then we did the single pass photoreoplasty, and he ended it with PDEC. So I thought I'll cover this particular topic for you just now on how to do this particular procedure of multiple procedures in one case, saying that I want to thank once again the Iranian Ophthalmic Society for asking me to come and speak in this thing, and I'll stop sharing my screen now. Thank you very much.
Thank you, Dr. Amar, for this wonderful talk. There are a few questions for you. There is one question from the audience. They are just asking that why do you prefer to use a trocar anterior chamber maintainer over a pars plana trocar insertion? And why do you prefer a young PDEC donor? The advantage of the young donor is very simple. I never take a donor above 35 or 40 years, because if you take a young donor, obviously the endothelium is much better. Imagine if I have to take a 60-year-old donor rather than if I'm taking a 20-year-old donor. It makes common sense to understand which is better. The second big advantage in the trocar AC maintainer, which is a question which you have asked, is if I use a pars plana trocar, I can use a trocar AC maintainer. For anterior segment surgeons, I suggest use a trocar AC maintainer, because you are not worried whether your pars plana trocar has gone into the subretinal space or not. Here you are seeing it. It's directly in your visualization. It's above the iris.
When you pull it out, it's absolutely self-sealing, just like a retina trocar. That's why a trocar AC maintainer is extremely helpful. In such complicated cases, I have it in the pars plana and in the front I have air. So whenever the chamber is shallowing, I can always push it from the back, because one of the problems is to unroll a graft in patients with vitrectomized eyes. But by fluid in the back, that problem is solved because the iris IOL diaphragm comes anteriorly.
Dr. Himanshu Mehta, would you like to comment on this? Would you like to do this as a single stage procedure, or maybe as a double stage procedure? Any tips on that? Dr. Himanshu Mehta, are you there? So, okay, I would just ask you directly, Dr. Amar, have you ever considered doing it as a two-stage?
We can do this in 2 phases. If by chance you don't have a ready donor available, then what I suggest is you can finish the glued IOL and the photoroplasty, wait for a good eye. When the good eye comes, I can do it as a 2-stage procedure. But if I have a ready-made donor ready available at that day, I will finish it in 1 step. So again, I think the solution is basically depending on what the surgeon's comfort is and the availability of the cornea is. But one thing is there, if you are moving into PDEC, which I advise everyone to do, because we do approximately about 100 keratoplasties a month in the Agarwal group. And in this, we do 0 DMEX and 0 DSEX. The reason is very simple. In DMEX, if you even touch, it can tear. Here in PDEC, that graft is absolutely rock steady. Nothing will happen because there's a pre-desmase layer which splints the tissue and makes it much stronger. The second biggest advantage in PDEC is you can easily use young donors. The youngest we have used is a 9-month-old donor with great results.
Thank you so much. Dr. Qureshi, you want to ask something?
There's no question. How do you insert your needle? Is it up, bevel up or bevel down?
Bevel up. You can have the bevel up, go just about 0.5 millimeter from the limbus, and when you go inject it, you are just under in the stromal area and just inject it till you get a good bubble. Then you can expand the bubble. Remember, don't expand it to the periphery. If the bubble goes to the periphery, that means you're creating a DMEC graft, because then the air is between the endothelium, desmase, then the air comes. That's a type 2 bubble. The bubble which I showed you, if you notice, it does not go to the periphery. That's a type 1 bubble. That will mean it will get a PDEC graft.
Okay, how deep do you go with your needle?
I don't go too deep at all. So I'm seeing my endothelium, I'm seeing my desmase, and I'm somewhere in the stroma in between, and I'm injecting it. If you go, let's say, too deep, let's give an example, you've gone too deep, you have perforated the epithelium. So it doesn't matter. Even if by chance you perforated the epithelium, just come out, start making a fresh opening. That's all. If by chance you've gone too deep, let's give an example, you've gone through the epithelium, it does not damage your endothelium anyway.
Thank you very much. Excellent. Can you go ahead with other speaker? Can you introduce?
Thank you very much.
Thank you.
Yeah. We move on to our next speaker, Dr. Ashwin Agarwal. He is a young dynamic surgeon and he's the director of the Clinical Services Agarwal Group of Hospitals. So Dr. Ashwin Agarwal, he'll be showing us some of his beautiful surgery on dangling and dropped intraocular lenses. We move on to you, Dr. Ashwin.
Yes, thank you so much. I was on mute and I was not allowed to unmute. So I'm now just going to share my screen. If everybody can see my screen, let me know. Is my screen visible?
Yes, go ahead.
Okay.
Good morning, good afternoon, and good evening. Today, my topic is the dangling IOL to a dropped IOL management. I am a consultant for ELISA, but none of it pertains to my talk today. Let's move on. Here's a case of subluxated capsular bag IOL complex with an endocapsular ring. The minute I see a 3-piece intraocular lens with a subluxated bag, my tendency is to go towards a glued intraocular lens as a preferred technique of mine. Here I'm making vertical flaps. Next, I'm placing a trocar AC maintainer to have infusion all the time inside the eye. Under the flaps then, I'm making my sclerotomies approximately 0.75 to a millimeter behind the limbus. Now, holding on to that endocapsular ring, not yanking, I'm performing my anterior vitrectomy and bag remnant removal. Once I've been able to remove enough of the bag remnants and perform enough of the anterior vitrectomy, I grab with the forceps or the glued IOL forceps the haptic of that intraocular lens that is already inside the eye and externalize it used through the sclerotomies. But inadvertently, in this case, I've also managed to break and pull out the capsule tension ring. Once I am now done with a little more of anterior vitrectomy and back remnant removal, I then externalize the next or the trailing haptic in this case to ensure that my haptic and my intraocular lens are now stable. Making my Gebauer-Charriot's tunnel, I tuck these haptics into the Gebauer-Charriot's tunnel, thereby stabilizing my intraocular lens. I now perform anterior vitrectomy in the anterior intracameral space with triamcinolone to ensure there is no vitreous in the anterior chamber. This now helps me also denote a problem. Optic capture can happen and with the iris, and that can be avoided in the post-operative period by simply doing one single pass photothrough looping it from one side and passing it 4 times. I now pull both the sides apart, thereby closing that gap which was present and thereby not allowing that optic of the intraocular lens popping up. I remove my infusion, place my air bubble in place, put some glue under the flaps, and that's pretty much the end of this case. Here are some of the post-operative pictures of the same case for your viewing. The patient achieved 6/6 vision. Moving on to a bigger problem, the dropped intraocular lens. Leaving a dropped intraocular lens inside the eye can cause a lot of problems, such as vitritis, endophthalmitis, and all these complications seen here. What are the procedures that are followed up until now? Let's try and understand that. The first step that people perform when they have a dropped intraocular lens is a core vitrectomy. Next is an IOL lifting forceps is used to lift off that intraocular lens. Different shapes of IOLs, different problems. The third, they might use a PFCL to actually float that intraocular lens into the mid-vitreous cavity and then lift it. Next, they may reposition this intraocular lens into the sulcus, or if you don't have good enough sulcus support, then a glued intraocular lens is then performed. Sometimes it may need to be extruded from outside and then a new lens implanted as a glued intraocular lens. What are the fears, risks, and complications of doing this? First, the proximity of the forceps to the retina. It might cause an edema, a hole or a tear, and even hemorrhage that aborts the case. Most often, inability to pick up the intraocular lens is a big issue. PFCL has also known to cause their own set of complications. So, what's the solution to all of this, fears and risks? Well, introducing the extrusion cannula assisted levitation technique, better known as ECAL. The extrusion cannula is a simple device that is used in retinal detachment surgery to drain the subretinal fluid. It's got a steel body and an inner silicone tip. It's used to drain subretinal fluid. In ECAL, I'm using the same device without the soft tip to actually occlude on the optic of the intraocular lens and bring it up into the pupillary zone. Just like this, smooth optic of the intraocular lens and the lumen of the extrusion cannula helps me lift this intraocular lens into the pupillary zone for me to externalize or remove the intraocular lens. Again, foot pedal is not pressed until I adhere to the optic. Once I adhere to the optic, it's pressed full swing at 400 vacuum. Positioning. Do not hold it when your occlusion to haptic tip position is long. Hold it in a position where your occlusion to a haptic tip is short. This way, when you supinate your hand and bring the haptic into the pupillary zone, you're able to externalize it very easily and not have to supinate your hand a lot more. Look at this. All I have to do is turn it to an angle where my occlusion to haptic tip is short. Now, externalizing the IOL is a 5-year-old's game. Next, we then include or reposition an intraocular lens with the secondary IOL of your choice. It could be an AC IOL, it could be a Yamane technique, could be a glued intraocular lens, any technique. My preferred technique is the glued intraocular lens, and hence you watch me doing the glued IOL technique in these cases. This is the end of the case in a ECAL technique to lift an intraocular lens that has dropped into the retina. Thank you very much, and glad you're watching. Keep watching more.
Well, that was a great video, Ashwin, both the videos. It's a great technique, ECAL. Could you give us some tips like Do you get enough occlusion? Do you face the IOL again dropping back onto the surface of the retina or something?
Yeah, I mean, that's a very interesting point, Priya. I think the most important point is that occlusion to the haptic distance. You know, if that distance is too long, even a little bit of supination, there's a lot of tilt that happens, and that touches the iris. You know, the haptic touches the iris, and you lose occlusion. This works on the same principles a vacuum works, right? You touch a vacuum to a plate, it basically will, if you release the vacuum, the plate falls off, and it's the same principle. So just keep that distance short, ensure that you come to the pupillary zone and then catch that haptic tip. That's the basic tip I can tell you. I haven't actually lost any IOL on the retina or in the mid-vitreous space while coming up ever. Even if you use a 50 vacuum or if you use a 400 vacuum, you can still go ahead with it as smoothly as possible. The only other tip I'll tell you is not to use it if there's any vitreous inside the anterior chamber or in the space. So that do a proper vitrectomy is important.
There's a
Okay.
question for you, that how far from the limbus do you make sclerotomies in blue dye?
It's a very good question. And, you know, in some cases, I've gone to less than 0.5. And in some cases, I've even gone to 1.5 and found that there's actually not much, so much difference. It's all about the angling of the needle as well, right? If you go a lot more horizontal or plane to the iris, then you're going to cause an iris root tear, or you're going to make that tunnel a little longer, and that basically increases the length as well. But if you go directly vertically down, then it's much more easier and faster for you to reach that vitreous
For the
space.
benefit of all, would you like to say in which cases would you go for 0.5 and which cases would you go for 1 or 1.5?
If it's a white to white is too large, I would go for something shorter. If it's 1.5, I would go for a normal 11 millimeter white to white or something like that.
Yeah, that's perfect.
Okay, thank you, Ashwin. Excellent as always. So I asked Dr. Mr. Rezai to unmute all the speakers, but if because of shortage of time, I don't ask any questions from the panelists. So I asked my Iranian colleagues, our colleagues that are panelists, if they have any comments themselves, please give their own comments. So we are not going to have to ask any questions because of shortage of time.
Dr. Himanshu, do you have any questions?
Do you have more questions? Can we leave some questions at the end of the webinar if I have time? So maybe some questions.
I think we need to unmute Dr. Himanshu. He's muted, so he cannot comment anything.
He cannot unmute him because
he cannot unmute himself. So please do, if somebody can do that.
Our technical team couldn't unmute him. I don't know why. So I asked, okay. Can you introduce the next speaker, please?
Yeah, our next speaker is Dr. Gaurav Luthra, and he's the chairman ARC of Indian Intraocular Implant Refractive Society and a very eminent ophthalmologist. And he's going to show us and talk on battling the bulge on intumescent cataracts. So Dr. Gaurav, it's all to you.
Yeah, thanks, Dr. Priya. Thanks, Dr. Goreshi, and thanks to the Iranian Society for inviting us to be part of your meeting. And I'll just share my screen. So I thought, we are going to cover two aspects of intumescent cataracts today. After I speak, Dr. Rohit will be talking about what happens after you have the broken capsule. I'll try to cover up what happens before you get the broken capsule and how to prevent that. So the challenges when dealing with the intumescent cataracts are several. You have a very shallow chamber. You would have high intralenticular pressure. And some of these cases will also have an upthrust because some of these eyes are small eyes. And then always there is that risk of a runaway rhexis, or you could have the rhexis tag prolapse through the incision, through the main incision. And then eventually some of these eyes will go into a flag sign. It's not common, but when it happens, it can be a big disaster. So there are many options when trying to deal with these cataracts. The soft shell technique for the viscoelastic is something which many of us use efficiently for this. Some people have proposed to do a yak capsulotomy of the capsule in the pre-op period. I've never done it, but for some people it seems to work well. Most would like to decompress the lens before they go in with the rexus. And there are several ways to do that. Some people like to do a small quick rexus and then aspirate and then enlarge the rexus. Some of them would give a nick, some would not give a nick. There has been the puncho rexus described for many years by several speakers. It's not very predictable, so it can lead to sometimes occasionally runaway rexus as well. And then of course the spiral rexus or the zepto surgery which can be done, and then of course the laser assisted cataract surgery, which seems to work well in many people's hands. So since we have so many ways to do it, I wanted to just share the challenges and what you can do to preempt that. If you don't have access to all these machines, you can still manage well. And when you start dealing with an intumescent cataract, sometimes you will start having a situation where the chamber shallows and the rexus is trying to run away. Immediately put in more viscoelastic, and when you aspirate and try to decompress, you can still get a complication. If you're not careful, it can sometimes catch hold of the capsule, and then of course you can go back in with nicely injected viscoelastic so that your chamber is nice and deep, and then you can complete the rexus. But it does not always work like that, and sometimes you will have a situation where, as you're doing the rexus, as in this, I had to actually pull out this video from an old one because it shows very nicely that when you come very close to the main port, and if you're not using a micro rexus and you're using just a regular rexus forceps, and in a patient with intumescent cataract, the capsular tags can start coming out of the main port, and this can complicate the surgery because this can suddenly lead to an extended rexus, and then you have to manage it. You can snip it there, you can try to put it back with viscoelastics. Sometimes nothing works and it just comes out. So one has to be careful. And sometimes when nothing else has worked and you try to deal with an intumescent lens, sometimes it will just go like that and give you the typical Argentinian flag sign. So what all can you do to prevent that? There are many ways to handle it, as I told you, and I'll show you my preferred technique. Some of the things that I've dealt with. So there you could see that I decompressed the lens after making a small nick. This is a pediatric cataract. And sometimes you have a pediatric cataract which is really intumescent. And using a good micro rexus forceps is always going to be useful. So start with a smallish rexus, but then of course you will want to make it bigger. So once you have a smallish rexus, then you can safely enlarge the rexus by doing a spiral rexus. And you can see here that after my initial rexus was there, I wanted to make it of the right size. So this small frill which is there will never run away. If you have enough viscoelastic inside, this is something which is very, very safe to do. Of course, it requires patience, but it works. And what I currently do is this technique where I decompress the lens, but not from the main port. So you'll see here that this is a nice intumescent cataract. And after staining, you can just go and fill in viscoelastic. And then don't use any of the ports like the side ports or the main port. You can go in with a 26 gauge or a 30 gauge needle on a 1 ml syringe, go in from a new paracentesis port, and you can puncture the lens right in the middle there. And as soon as you puncture it, you can aspirate. Now the advantage is that the chamber is always going to be nicely filled with viscoelastic. When you go in from a regular incision, you tend to depress the posterior lip and the chamber becomes shallow, the viscoelastic comes out. Here, nothing like that happens. So in a stable chamber, it's much easier to decompress the lens in a more controlled way and then complete the rexus. So that tends to work. And another patient here where we were trying to do a rexus, I was going to follow the same technique as I've shown you before. And here, we thought that it's a very, very intumescent cataract. As soon as we did the aspiration, it seemed to work well. But in spite of that, sometimes it will, still have a situation, as you will just see. As we come out, we notice that the area which was under the area where I aspirated, because I went and aspirated there, it's starting to extend in the other direction. And then you have to quickly come around and you can manage it. Of course, you must have good plastic again. So these are the situations which can happen. How can you preempt this? Now, this was another situation where I thought if I just do an aspiration, but here I didn't even get a chance to aspirate it, straight away went into a flag sign. So sometimes nothing will work. So how do you decide whether you can deal with a cataract? So I think the AS OCT, the intersegment OCT, is really nice. You can image the intumescent cataracts and predict the lenses which are likely to go into a situation like that, and maybe offer them femto-cataract surgery. And this is another situation where you'll see that there is enough intumescence over here and a very shallow chamber. And you can also see it on the slit lamp. So it's not necessary to always do an OCT. As you can see in this image, you can see these fluid-filled pockets just behind the anterior capsule on a good slit lamp examination, and you can predict which are the eyes which are going to go into that situation. You can look at the anterior chamber depth if it's very shallow. So these are all predictors, and then you can use all these special techniques. This is my last slide. And I prefer to use the femto in many of these cases. Yes, expenditure is a problem, but sometimes you can subsidize it for the patient. And many times if you convince them to go with a femtosecond surgery with maybe a slightly cheaper lens, you can offer them a more subsidized package. It tends to give us much more predictable results. And we found that if you have access to a femtosecond laser, it would help you. And I'll finish after this slide. So here we can see that we've done the planning, and you can see the intumescence of the lens, and actually you can see the subcapsular intumescence over there. And as you notice over here, once we fire the laser, you will be able to appreciate how it's almost like a nuclear explosion or a mushroom kind of an explosion there. And you can get tags, and you can get still capsular problems, because as the intumescence goes away, sometimes you will get capsular tags. So you have to be extremely careful. So you saw that that mushroom cloud over there, and then of course it can go into a situation, but 99% of the times it works. So take home message, a good slit lamp exam can be really useful, because you can see the intumescence, and you can see those intumescent pockets behind the anterior capsule. You should have an eye on the AC depth. When I start operating these patients, I always have a quick look at the AC depth. If it's really small, I have to be well prepared with good viscoelastics and all the other techniques. And OCT can predict quite well. And chamber stability must be maintained at all times. Decompress the lens for sure. And a good control on the rexus with a good micro-rexus forceps from the side port. And very good instrumentation can preempt from getting into a situation like this. Femto-assisted surgery can help. With that, I will stop. Thank you so much.
Thank you. Thank you very much, Dr. Luthra. Is there any question from audience? I think I don't see any question from audience. If any of the colleagues have any comments, please go ahead with your
comments. I have a comment.
Dr. Zari, please.
Hello, Dr. Luthra. Hello, everybody. I just want to add one more technique that you could use. You show almost all of them. Sometimes as I go bevel down with the phaco tip with the high vacuum and just make a small hole in the intumescence cataract, a small hole in the capsule. Sometimes it works. Sometimes, again, you have an Argentinian flag again. Thank you.
I understand. Yeah. So we call that a puncturexis in India. So I mentioned that, but I didn't have a video. But yes, even Uday Devgan probably uses it. So
perfect.
Thank you very much. There is other question from audience. I don't know who has to answer that. How far do you go from the limbus for glued IOL?
I'm sorry?
Can anyone answer that? The question is, how far do you go for glued IOL from the limbus?
I think Dr. Amar or Dr. Mahipal or Priya can answer that. Ashwin?
Yeah, I think that question, he already answered that
okay.
question.
Yeah.
Okay. So do we go ahead with the next speaker? Next speaker is my co-moderator, Dr. Priya Narang. She will talk about iridodialysis, repair, and pupil reconstruction.
Can you see my screen? Is it visible?
Yes, please.
So, at the outset, I'd like to thank Dr. Qureshi for inviting me and the Iran Ophthalmological Society for having me here. Well, I will be covering up iridodialysis and pupil reconstruction, because this is also an essential part of any challenges that we come across in the cataract surgery, and we need to take care of this aspect too when it is being done. So I'll be just showcasing one or two techniques which we can incorporate into that. So this is the first technique. This is the single pass 4-through pupilloplasty. I'm just trying to show you the animation of this, how this technique is being done. This was described by me and Dr. Amar. We described this 2 years back. This is the 10 suture or a 9 suture needle, which engages the proximal and the distal part of the iris tissue that is to be approximated. And then you just withdraw a loop from the paracentesis incision and the suture end is passed through the loop 4 times, and you just pull on both the sides of the suture, and this loop, it easily slides into. And that's all. You are all set and done with just single pass, and we take 4 throws. So that is how this technique it derived its name. So I'll be trying to put up this procedure into various clinical situations in the future. In the future videos. This is a case where you can see a cataract surgery has been done, but somehow the superior portion is lacking the contour that we really need to have it in the post-operative period. So it is decided to do a single pass photocoupleplasty in this procedure. And as you can see, the nanosuture needle, long arm suture needle, is passed through one of the proximal end, and it is withdrawn from the distal end. And this is how you just take up you make a loop of this. You can use a Sinski's hook or any other device which has a good which can go into the anterior chamber, and it can create a loop for you. You can even use an end opening forceps. Once you get this loop out here, what you're seeing here, you just have to take 4 throws in a similar direction through this loop. And then you just pull both the ends, and this goes back. So this procedure you can keep on repeating till you go on to complete this entire defect into the iris. So this is the second pass which is being taken up just to clear up this iris defect. So I move on to the next video. This is the two-fold technique. The two-fold technique which we had described, it originally describes a combination of 2 procedures, which is the non-appositional repair of iris along with single pass 4-through pupilloplasty procedure. So I'm just trying to show you the animations first. When you have a massive iridodialysis like this, what we initially do is we use the non-appositional repair of iris, and then you suture up the base of the iris. It is sutured into place, and then for the correctopia or for the updrawn pupil or whatever, you can use a single pass 4-through pupilloplasty procedure, and you can have a combination of these 2 procedures, and that gives you a perfect outlook. There is a different way of incorporating the two-fold technique. When you have a moderate amount of defects, what you can do is you can initially close down this defect with the single pass 4-through pupilloplasty procedure. So then what happens is that you just need to take 1 pass of the non-appositional repair, and then you are done, because you're just narrowing down the defect which was already present there. Otherwise you would have had to take this at least 4 passes. So you can do this procedure, which is a combination of these 2 techniques, which we published in JCRS last year. So this is a clinical video of how to go ahead with the two-fold technique. Here you see there is a superior defect, and a lot of iris prolapse was there. This was a complicated surgery which had occurred, and you can also see chaffing of the iris tissue which is there, and the iris tissue is just friable. From wherever you pass the needle, it just tends to gape and it goes off. So we're trying to reconstruct pupil. In this situation, you have to be very careful from where you pass the needle, because it might gape from that portion. And that's what you're actually going to see in the surgical video, how it keeps on giving way at every moment that you are trying to reconstruct. Every moment you feel that you are done with the procedure, but yes, you have another procedure coming up because it's giving way from one side or the other. Now what happens here is there is a defect here in the, this is the iridodialysis which is present here. So we just try to flatten out the iris tissue out here. And once it is flattened up, we go ahead with the non-appositional repair of the iris tissue. The scleral groove is passed, is made, and then you just take, this is a double arm suture which we try to use for the non-appositional repair. So now this is the repair of iris tissue goes on till you try to get and optimize the size of the pupil that you are actually desiring to have it in the post-operative period. In this case, actually there was a massive iris tissue defect in the entire superior 180 degrees. The pupil contour was not there. Apart from that, there was a complete gaping of the iris from the base of the iris situation, from the base of the iris insertion rather. So you can just see that these are the multiple approaches that are being taken here to reposit the iris tissue and to achieve the contour that we actually desire for this patient. This is actually a beautiful way of doing it, and as we all know that non-appositional repair, which has been described by Dr. Snyder et al., it's a beautiful technique. The best part of the non-appositional repair is that it prevents any post-op, it gives a hang, it's also known as a hang back. The name has derived because you do not exactly pull the iris tissue up to the scleral area. So that is what they say, that there is less amount of intraocular pressure rise, and the iris tissue just it does not clog the trabecular meshwork area, and you do not have a post-operative inflammation, you do not have a post-operative rise, you do not occlude the trabecular meshwork. So that is what's the advantage coming up with the hangback procedure, taking it up with the single pass 4-through pupilloplasty, and that is how the two-pole technique works. This is just a small animation that I'm just trying to show you. This is a trocar-assisted iridodialysis repair, because you can do it even without a trocar, but you can use this, or maybe you can use an iris spatula. You can just keep it and slide the needle above it. The advantage being that, you know, you do not tend to incorporate the corneal tissue when you're passing the needle. So that prevents the failure. Otherwise, what actually happens is that when you try to pull the suture, if the suture is engaged somewhere here, it just does not slide inside, and that's a failure of the procedure, and maybe you need to redo the procedure. So these are some of the short things which are very important whenever you have an iris tissue repair coming up in any complicated cataract surgery. So I would just wind up with this. So thank you for your attention.
Thank you very much, Dr. Narayan, for excellent and informative presentation. Can you take over while I am preparing my presentation? Because alphabetically, I am next. Maybe in the list.
I can take up the questions. Yes. Yeah. If there is any question for me. Meanwhile, I think we have Dr. Qureshi coming up. I think there is one question. How far from the pupil border do you pass the needle for single pass 4-throw pupilloplasty? It depends upon the amount of the iris tissue that you want to involve into the needle, into the tip of the needle, because at the end of the day, the amount of iris tissue that you involve, that is the tip of the needle, when it incorporates the proximal and the distal part. If you incorporate too much of iris tissue, it's hazardous, because what will actually happen is that you are going to create a lot of pull. With a lot of pull, you know, the iris, you will be creating iatrogenic iridodialysis, because you'll be pulling off too much of iris from the periphery into the center. So that you have to be very careful. You have to actually judge this. I cannot just tell you that, okay, you have to grab 0.1 or 0.2 or 0.3 mm of it. You have to judge it intraoperatively, that how much amount of iris tissue you actually want, because that is the amount of tissue that will be creating traction on the periphery of the iris also. So you have to be very careful. You have to balance how much amount of iris tissue is to be involved into this. So I think with this, we move on to Dr. Qureshi. Dr. Qureshi, we look forward to having your talk. Dr. Qureshi is going to talk on corneal carving and shaping to reduce the high post-op RK cylinder before phaco.
Okay, I am trying to share my screen. I am not sure if you can see my screen or not. Can you see my screen?
Not yet.
Not yet. So. Mr. Zai, I don't have the option to share the screen. Okay. I just a moment. I am not sure. I don't know what is this.
Dr. Qureshi?
Yes.
Would you please open your file before share screen?
Okay, open my file before share screen. I'll try to do that.
After opening your file, you can share screen and select your file.
Okay, my file is open now. And I am trying to share the screen. I cannot see my file. I don't know why. It says Google. I have here Microsoft Drive, Microsoft. Okay. Can you go ahead with other speaker? So I don't know what the problem is.
Yeah, maybe. Yeah. There's one small question, that how long do you cut the suture ends? It's in SFT. It's about 1 millimeter. So that's it. We move on to our next speaker. Meanwhile, Dr. Qureshi, he adjusts his talk. We move on to Dr. Rohit Om Prakash. Dr. Rohit Om Prakash, he's a very leading ophthalmologist from Amritsar, North India, and he's the main person behind the winter IRSI that we hold it annually. He's going to talk on anterior capsular tear and intumescent cataracts and what next.
Thank you, Dr. Priya. Am I audible? Is my screen clear?
Yes, yes, we can see it.
Yeah. So, I would like to thank Dr. Amar Agarwal for this opportunity. It's a great cohesion between Iranian Ophthalmological Society and the Intraocular Implant and Refractive Society of India. I would like to thank Dr. Gaurav for taking up and easing up my presentation. So I would be talking about anterior capsular tears in intumescent cataracts. What next? So in trying to create a rhexis in an intumescent cataract, we invariably, at times, not invariably, rarely end up with an anterior capsular tear. So what next? Well, we are at a crossroad of surgical dilemma because we have two plans now. Either we convert to extracapsular or we continue with phacoemulsification, because of the simple fact that phacoemulsification can be completed in a good chunk of patients, but there are situations where we end up with a nucleus drop. So why this surgical dilemma? This is basically because of the fact that there is uncertainty about the tear extent. We are definitely not sure what the peripheral extent of the tear is, whether it is pre-equatorial or whether it has become a wraparound tear. The second most important part is whenever a posterior extension occurs, we cannot appreciate it because there's a time lag for the appearance of signs of posterior capsule rupture, and the surgeon variability factor is also there because of the simple fact that it depends upon the experience of the surgeon at times. So what is the answer to this surgical dilemma? Well, the answer is you should know about the flap motility sign, and in addition to the flap motility sign, you should use the safe techniques. Now, let me get into what this flap motility sign is. Well, this flap motility sign for posterior capsule rupture is a sign which is there in the peripherally extended anterior capsular tears. Now, what is this concept of flap motility sign? If the flap, mark my words, are fluttering and everted, they are pre-equatorial by all means, because of the simple fact that the end point acts as a pivot, and it, in response to the fluidics in the anterior chamber, it flutters. And when it extends beyond the equator onto the posterior capsule, it stops fluttering and becomes inverted. You will find that it is no longer everted. It stops, it becomes flat, and eventually it becomes inverted. Now, basically, we have a high pressurized anterior segment and a low pressurized posterior segment. Whenever there's a breach, there are no two compartments, subsequent to which there's a negative pressure in the posterior segment. And because of the high fluidics in the anterior chamber, the anterior capsular tear gets pulled down and there's an anterior increased capsular bag volume. So basically, this creates a flat or a inverted non-fluttering flap when it becomes a wraparound tear. So now in this video, let's see how do we come to know whenever there's an anterior capsular tear, whether it is pre-equatorial or post-equatorial. The moment you introduce the visco, you will find this lower one has become everted. This shows that it is pre-equatorial. Now, when we introduce the fluidics, it has started just focus on these stripe-induced stained flaps. You will find that they are fluttering and they are inverted at times. I am doing the sculpting. I'm increasing my gauge at the same time. The moment I divide it, partially I recheck and I find that it is still fluttering and everted. This shows it is pre-equatorial by all means. And then the next step is rotation has to be, it has to be minimal, but you will find that it is still fluttering and everted. This shows that it is pre-equatorial by all means. And now I'm going to pull it out into the supracapsular area and continue with the emulsification. And at this point of time also, you will find that it is now the chamber is stable, and you will find while doing the IA, it is still, you will find this flap still everted and fluttering. This shows it is pre-equatorial. The intraocular lens is also in place, and still it is fluttering and everted. So no confusion, total clarity what the extent of the flap is. So with this, the moment you find, now when I'm doing stromal hydration, see, it's fluttering. So this shows that even at the end, it is fluttering. This shows that it is pre-equatorial by all means. Now, now let's see a video in which you will find that the resident who was a fellow with us trying to enlarge the rexes inadvertently created an anterior capsular tear. So he's continuing with the, creating the valley. You will find that the flap is everted and fluttering. And the moment he divides, it has stopped fluttering. So that is the time when it became a wraparound tear. So oblivious of the relevance of flap motility sign, he continued. He ended up with a situation wherein there was a nucleus drop. So this is the relevance of the flap motility sign in such conditions. So we come to know about the endpoint of safe phacoemulsification. So this is, this endpoint is, you will find, this is the point when it stops fluttering and it has become inverted, that conversion to, SICS or the other method is manual small incision cataract surgery should have been there. So this is what it is. So the next video is the safe phacoemulsification techniques are very important. See the incision site. It is not parallel. It is at an angle. The second point is when you are doing, low IOP. So you're creating stable chamber settings, low fluidics by all means. I'm not pushing while sculpting. That is the next point, which no wide separation has to be done. And the separation has to be in this axis. It should not be at 90 degree, because then if it is at 90 degree, you will end up with a situation wherein you can create a situation where it extends beyond the equator onto the posterior capsule. Minimal rotation. Now, once this is there, once you are again dividing, try to create less amount of separation. And the separation forces are also in this direction, as you will see with the cursor, which I'm trying to show. So supracapsular emulsification is the next step, which has to be evolved. So these are the different techniques which have to be done while doing safe phacoemulsification techniques. So once we are done with this, we can invariably end up with conclusive results. Summarizing, do not panic, flap motility sign is there. I've already talked about it. And the safe phacoemulsification techniques not to forget. If the plan doesn't work, change the plan, but never the goal. Thank you very much, Dr. Priya, for the opportunity.
Thank you, Dr. Rohit. This was just a wonderful presentation, a wonderful concept and video, and beautiful discussion. So, Dr. Ivanshu, would you like to comment something on this? You are doing so much of cataract surgeries. You are a pioneer. We'd like to listen from you.
Thank you, Dr. Priya. Finally, I got unmuted. I get a chance to speak. And for none other than my dear friend, Dr. Rohit Om Prakash. I think he's found a wonderful sign, that flap motility sign, which should be a land torch, the most important torch bearer for most people who are afraid when the tear runs off to the periphery, whether or not you're getting vitreous into the wound or not. But as usual, the parameters will go down. As he said, do not too much of lateral separation, not too much of fluidics that is going around, not too much of monkeying around over there, and getting into the anterior chamber. You're lucky if you're some myopic kind of a patient where you have a deep anterior chamber. The problem starts when it's a pregnant kind of a nucleus, very big nucleus, small rexes and or running off to the periphery, and a small anterior chamber, wherein you have to save the endothelium. So dispersive kind of viscoelastic would help you at that time. And I think what he has shown is a very important sign. Subconsciously, you will always be very sure that you can be dealing with what you are and you can go ahead with it. Rohit, one question. When does this flap motility change from eversion to inversion? Does it change?
Yeah, it does. Whenever it extends, it becomes a wraparound tear from a pre-equatorial tear. That is the time. So that is, just instantaneous. So that is the time when conversion should be done, because this appears much before the classical signs of posterior capsule rupture.
So the most important thing, keeping a third eye, very, very important, because when we are doing the nucleus separation, lateral separation, we are doing the phacoemulsification, you are generally concentrating on the nucleus, you are not looking at the periphery. But the angle of the eye should be very clear at the flap which is moving. If it stops moving or it starts inverting, stop, fluidics, push in on the side port something so that you're dispersive or cohesive viscoelastic, come out, change your plan of action, stop for a little while, because the more longer you persist inside the anterior chamber with high fluidics, it will definitely go behind and tear the capsule. Thanks, Rohit. Thanks so much for this lovely sign that you discovered.
I think this was wonderful. We move on to our next speaker, Dr. Mahipal Sachdev. Dr. Mahipal Sachdev, he is the president of All India Ophthalmological Society and he's the chairman of Center for Sight Group of Hospitals, India. Dr. Mahipal will be talking on third hand in phaco.
Thank you very much, Dr. Priya and Dr. Qureshi and the Iranian Ophthalmological Society. My pleasure to be here. I'll be talking about from the third eye, which was mentioned, to the third hand. So is my screen visible?
Yes.
Yes, yes.
Yes.
Okay. So what I'm going to be talking about is cases where you have a problem in a posterior capsular approach, where you want to do a posterior capsular approach, and this is a case of a traumatic cataract where there is an anterior capsular tear plus there is a posterior capsular tear. So we have already prepared by doing a trocar cannula and put an infusion from the pars plana, and now we are going to use the vitrectomy cutter either for aspiration or for cutting, where we can change. Now if you do an anterior approach, you will be hydrating the vitreous, and once you hydrate the vitreous, there will be more vitreous that is coming out. So you can see a large posterior capsular tear, and now we have gone through the pars plana approach, and this is the best approach that you want in this particular case. And depending upon irrigation vitrector aspiration or irrigation aspiration vitrector, you can do that to remove the cortex or the nuclear fragments if there are any. Now this is a hydrated, obviously a post-traumatic hydrated cataract. And you can see now we are just doing an aspiration without cutting. You can see this is an aspiration that we are doing without cutting. And in this particular case, again, we are doing an aspiration. You can see here, and this is an aspiration that is being done for these particular cases. Now, since there is a large anterior and a posterior tear, we have to do a good vitrectomy, which we have done, and remove the entire cortex. And we will go in with a sulcus implantation of a 3-piece lens. Normally you don't want, you can see that it is going back. So you are using the posterior approach to levitate out the nucleus so that it does not fall, and you can easily put it at a perpendicular angle to the tear. So you can see that we are putting it at 90 degrees from the tear which is there into the sulcus, and this 3-piece lens will give you a good position which the patient will behave well. If it was a capsular axis, you could do a posterior capture. And let us look at a second case where you see a pre-existing zonular dehiscence with some amount of vitreous that is coming out. Now, how would you wish to take this particular case? So we took a femto. You can see in a femto the OCT image has come, and you can see these are vitreous blobs that the OCT can show, and you can see that this is a globular anterior capsule because there is a subluxation which is there. Now with the catalyst system, we are able to get a good view, and we are making the anterior capsule come in line, and then we are looking at doing a scanned capsule center capsulotomy. Since it is cutting the iris, we reduce the diameter, and once we reduce the diameter, you can see that again it is cutting the iris. So what we will do is that from there we will move on to a manual guiding area. So you can see that we go on to a customized centration and try to decenter it to an extent that we will be able to have it the IOL centered and placed in the centers once the ring has been put. So you can see that even with the vitreous which is there, we are able to get a good capsulotomy. Once we get a good capsulotomy, we are also able to get a good nucleotomy. So see that this is going to also, there is an astigmatism that we are looking at. So this is going to give us a good outcome because the manipulation will be reduced. So if you look here, I'll just show you at this particular point, you can see that this is very well seen that there is a huge defect that was there, as zonular dehiscence, but you can see that a good capsulotomy is there and a nucleotomy that has happened. And we are using the third hand, as we say, that we are using the pars plana approach to actually have gone in with a trocar cannula and kept it there. Now let us just see as to what we will do is that we will decompress the vitreous that is coming out or the fluid that is coming out. And once we have done this, after injecting tricot, we will go in from the pars plana approach and remove the vitreous that is coming towards the wound that is there. And now we go ahead, and because the decompression of the vitreous has happened, we are coming here and we are removing the capsulotomy. Once the capsulotomy has been removed, we go ahead and put an endocapsular ring. So you have to be just careful that the endocapsular ring goes into the capsule. And now you can see that because there has been a nucleotomy that has been done, you are able to take away the nuclear fragments very easily. So these nuclear fragments are being taken away with great ease that is there. And once you have these nuclear fragments coming out, you have to carefully reduce it to the epinucleus mode and try and remove this epinucleus, and then use a bimanual irrigation aspiration to remove the pieces of the cortical piece remnants that are there, and the little bit of epinucleus that is there. Since there is an endocapsular ring that has been implanted, you would need to tease away the cortical fibers very easily, and you can see that this is what we have done. Now, without decompressing, you still have the infusion. You go and put viscoelastic from the other side so that the bag doesn't come up. And to get the additional support onto the capsule, we go ahead and put a 3-piece intraocular lens again, so that this is going to again push the zonular dialysis. Now you go back in, and in this particular case, again remove whatever vitreous that is there by using the vitreous from the pars plana approach that you are doing, and you have the infusion that is coming here. Now what we will do is that we will reverse it, and because there is a slight amount of vitreous that is sticking and you had used the tricot, you can see that it is stained. Now we will put an infusion again, and you can see that we are putting in the infusion there, and we will go from the side port that we had created and remove this tag of vitreous so that the lens becomes centered, and the vitreous tag that is there stops pushing. So you have a well-centered intraocular lens in this particular case again. So what I have tried to highlight in these two videos is that you can have a pars plana approach, take help from your posterior segment friends. And if you have similar cases where there is vitreous pre-existing rents, etc., where if you are following an anterior approach, there will be hydration of the vitreous, and doing a surgery would be very, very difficult. And also in subluxated cataracts, the treatment of choice would be a femtolaser assisted cataract surgery. And even if there is vitreous, as I showed you on the OCT, the capsulotomy comes out pretty well, because the laser capsulotomy does not recognize the presence of the vitreous. Otherwise, you have to use two-handed technique, etc., to even raise the first flap. There it is very difficult in case you have a sublux where there isn't a counter traction of the zonules in case of a subluxated lens. So friends, all that I will wish to say is that often a posterior approach is required to help the anterior segment surgeon tackle these difficult cases. Thank you.
That was a great presentation, Dr. Mahipal. Panelists, any comments on Dr. Mahipal's presentation on video? Any queries?
Yeah. He's done a wonderful job, Dr. Priya. He did a great job, but what he wants to say is that there should be some training either in doing a posterior segment surgery simultaneously, or you should have a vitreoretinal surgeon standby. That was most important. And the ease with femto offers here, wherein your rexis is ready, that makes life a little more easier. You know, how smoothly he showed the transition has to be seen. Excellent, Mahipal.
Thank you, Harsh.
So I think that was a great presentation. Thank you, Dr. Mahipal, for being here.
Thank you.
We move on to our next presentation. Next presenter, Dr. Qureshi, he'll be talking on corneal carving and shaping to reduce the high post-arcular cylinder before phaco.
Okay, I think, do you have my screen?
Yes, we can see your
We
screen.
have my video. Okay, it's okay now. Thank you very much. I'm going to present this case to you, and I'm sorry that the narration is digital because I just edited, and I had my voice over that, but I prefer to be digital, but still it's not elegant. So I apologize for that.
The title of this presentation is Corneal Carving and Shaping to Reduce High Post-RK Cylinder Before Cataract Surgery. Some challenges that we may face in this situation are as following: irregular cornea and irregular astigmatism, high astigmatism, IOL power calculation, and incisions. In this presentation, we will concentrate on astigmatism management in these cases. Patients can be categorized to the following groups and managed accordingly: irregular cornea with low to moderate astigmatism, irregular cornea with high and very high astigmatism, relatively regular cornea with high and very high astigmatism. When there is a regular cornea with low to moderate astigmatism, our preferred option is topper-guided trans-epithelial PRK to regularize the cornea and eliminate or decrease cylinder, followed by IOL power calculation and toric IOL implantation for residual cylinder. The image shows preoperative and postoperative topography of an irregular cornea which was treated by this technique. The cornea was pretty much regularized and the effect is more evident in the difference map. When the cornea is irregular and there is high and very high astigmatism, the case is much more challenging and difficult to manage, as this case, who has 18 diopters of irregular astigmatism and topography. Wedge resection may be a suitable option in some patients. Pinhole pupilloplasty, which was introduced by Dr. Amar Agarwal, may have good results in these cases. In this presentation, I am going to introduce an innovative technique which I have called selective manual ablation or photoselective keratectomy (PSK) in some of these cases. Before that, I am showing a case with very high cylinder and highly irregular cornea which was successfully managed by femto-assisted wedge resection. This patient, who had 13 diopters of cylinder with high irregularity, ended up with regular astigmatism in the opposite meridian, as is shown in early post-operative map. The residual cylinder was reduced by selective suture removal. You can appreciate this by comparing post-op, pre-op and difference maps. In the third situation, the patient may have high and very high astigmatism with relatively regular cornea. In such cases, high-power toric IOL can be an option, but availability, cost and measurement errors are the main issues. All the cylinder may not correct head, and of course these lenses are not as suitable when the cornea is highly irregular. In the following cases, I am going to present a technique that, in my experience, is safe and highly effective in these situations. This gentleman, who had history of radial keratotomy years earlier, was referred for cataract surgery. He had high refractive and topographic cylinder and irregular cornea as shown in topography and IOL master printout. Selective manual ablation technique was planned to reduce cylinder and improve irregularity. This technique is inspired by Sahan engraving art Galamzani. The art of comes on various metals, especially copper. Joystick control laser pulses applied over flat and elevated area of the cornea. This technique is possible with older version of B&L laser machine Technolus 217. PTK program with joystick control mode is used. The most elevated and flat hemi-meridian of the cornea is targeted. That in this case is inferior. Only the epithelium of planned ablation area is removed. Pulses are applied selectively with controls on the paracentral area, and the effect is monitored by keratoscopy. Mitomycin C is applied at the end of the procedure. Post-op results of a highly irregular cornea are shown here. The effect is better seen on keratoscopic rings. This is the case that was introduced earlier and had cataract and high cylinder. Cylinder has been reduced to -3.5 diopter and the eye is suitable for a regular toric IOL. After stabilization of refraction, IOL power calculation was performed using HagesL and Oculic software and was verified by Barrett and ASCRS online calculator. A toric lens with 18.5 diopter sphere and 5 diopter cylinder at IOL plane was ordered and patient underwent cataract surgery. CT guided marking and alignment as is shown here. Here you see the final outcomes and post-operative data. The patient was very happy. Uncorrected and corrected distance visual acuity was 20/25. Refraction was -0.50 with only -0.25 diopter cylinder, which is almost neglectable and was stable through 1 year follow-up. In conclusion, high corneal astigmatism after RK and before cataract surgery can be dealt with by different approaches. This novel technique called selective manual ablation or photoselective keratectomy (PSK) is safe and highly effective in regularizing the cornea and reducing high astigmatism before cataract surgery. Thank you for your attention.
Well, that was a great talk, and I think post-RK, they are one of the most challenging situations that we always face when we have to do a cataract surgery or we need to correct the refractive error in these eyes. So I would like cornea people to comment on this, and refractive people, like what would you consider? Dr. Namrata, do you have any comments on this?
I think Dr. Qureshi has shown a wonderful set of cases. In fact, very complex cases, post-radial keratotomy, very difficult to deal and highly irregular and aberrated corneas. And the results which have been shown in the different maps are quite spectacular. And I think this is one good way of dealing with these cases. And I just want to ask him if you can also use this technique of selective manual ablation in cases of post-keratoplasty astigmatism to treat it, before you take cataract surgery in those cases.
Thank you very much, Dr. Namrata Sharma. Actually, I have used with a few cases of post-keratoplasty astigmatism, but in these cases, I had to take a flap because, as you see, the superficial ablation in this case is risky with development of corneal haze. So if the astigmatism is very high, I remove the flap and do the same technique. I also have used this technique in many other cases like pellucid marginal degeneration. And in some cataract surgeries, in some keratoconus cases, I have used a circular resection with this technique and flatten the cornea centrally. I think before the others give any comment, I would ask my colleague, Dr. Jadidi, who has the experienced surgeon. He had another approach with such cases, but I'm sure that his cases was not as messy as my cases. So he used the customized the toric IOL in some cases, and if he is there, I would like to ask him to make a comment on that. And he also has a short video to tell us about the customized toric IOLs. Dr. Jadidi, are you there? If you are there, please. Okay, thank you.
Yes, I'm here.
Okay, can you comment on the approach that you have with this case? For this case?
Yes, your approach is very, very novel, and I think your approach is good for some selective cases. And as you know, we have a very problem with the post-RK patient because they have high astigmatism and irregular astigmatism. But in regular astigmatism, another approach has phaco investigation which customize IOL implantation. Please show my film. Please show my video. I will present a case post-RK and with customized intraocular lens implantation.
I asked Dr. Jadid to comment on that, but he preferred to have a very short video. So
yes,
he's ready, please.
Yes, I'm ready. Excuse me, Mr. Rezai, please start my video.
Before your video, can you explain about this lens? How do you prepare that? How do you measure that? How do you?
Yes, this lens from Care Group company from India, and I ordered this type of lens for different patients. For example, I use in this type of lens for keratoconus patient with -15 diopter of astigmatism. And I use for post-RK patient and post-keratoplasty patient with cataract surgery. I ordered to this company, and after they ready the PCIL, I operated them with this type of lens. And for the calculation of this lens, the first I used the IOL Master 700, and then I entered all of the data into the Barrett formula, and then I used two Ultima Smart Toric lens size, and I entered all of information such as surgical induced astigmatism and incision location and other data that need to use for calculation toric IOL. Then they prepared the IOL and operated the patient with this special lens. And this lens is good because the lens has some characteristics as a unique, such as customized size, customized power, and astigmatism. And the spherical equivalent is very good, this type of lens, because with a unique pad for the control rotation after the surgery. And if I don't know why my video prepared for shell.
Mr. Zari told me that he has not your video. So can you conclude, please? He doesn't have your video. So can you?
Why I prepare my video completely for this type of lens?
Okay. So he doesn't have what to do. Can you please conclude? Okay. Thank you very much. Thank you.
Dr. Jadidi.
So, yes. So
I have a question for you.
Yes.
In a patient with RK or keratoconus, the main problem is high order aberration. How do you correct them? I mean,
this lens designed for controlled spherical aberration with the anterior surface of lens is plus aberration free, and is desirable for the all of type of this patient, because the lens designed for this patient, and the anterior surface of lens is completely different to another type. The anterior, I thought about the negative spherical aberration with modified perolate anterior surface in this lens. So it's suitable for majority of patients, because the design of lens, especially for this type of patient. And I use for patient with regular astigmatism after RK or after nearly almost regular astigmatism.
Thank you, Dr. Jadidi, very much.
You're welcome.
You are short of time. I think we have to go ahead with other speakers.
Yeah, we move on to our next speaker. Our next speaker is Dr. Namrata Sharma. She's a dynamic lady. Very proud of her. She's the Secretary, All India Ophthalmological Society and a faculty at All India Institute of Medical Sciences. We look forward to listening from you, Dr. Namrata. She'll be talking upon intraoperative OCT guided phaco.
Am I audible?
Yes.
Okay. At the outset, I would like to thank Iran Ophthalmological Society and Dr. Qureshi and all the other organizing members for having me here. And I would also like to thank Dr. Priya Narang, Dr. Amar Agarwal for including me in this program. As well, nice to see my very good friend Dr. Ganavati, whom I know from before. And I would be talking to you about IOCT guided phacoemulsification. There are no financial or proprietary interests. And if we look at the video, all these steps, they become a lot easier if you have an intraop OCT microscope. For instance, you can see when the side port is being made, you can see where what is the depth at which it is being made. Then when you make a uniplanar incision or make a multiplanar incision, again, that can be seen. Then in case of capsulorhexis, as the capsule is being initiated, you can actually see in the same surgical piece that the rhexis is being initiated. And this is very useful, maybe not in these cases where it is quite clear, but in cases where corneal haze is there, where you can locate the edge of the rhexis. And then when you complete it, as the flap moves, so does it move on the intraop OCT microscope also. Then likewise, when you do hydrodissection, then you can actually see the fluid wave, which is separating the cortex from the capsule. This is again very useful in cases of posterior polar cataracts when you don't have to do this. And also it helps you to know whether any posterior capsular defect is there or not. Then the disassembly of the nucleus can be seen as the hydrodelineation is done. And then as a crater is made, you can actually see that the crater is being made here. And the depth of the crater can also be ascertained so that you do not go very deep. Now, the posterior capsule, moves up during your various procedures, and that also can be seen. And as it moves down again, it can be seen. So this is moving up, and as you put viscoelastic, it drops down. Then when the PC is intact, of course, that can be seen. And if there is a defect in it, also can be very nicely highlighted. Then as you inject the intraocular lens, that can be visualized on this. And most important is this. So this is the gap which is there after the insertion of the IOL between the lens and the PC. And as you aspirate the viscoelastic substance, then again this gap decreases, and that can again be seen intraoperatively. So you don't leave any viscoelastic behind. And as the hydration of the wound is done, you can again see that spindle forming here. And if there are any detachments which are there at the wound site, at the side port, or at the main wound, then again also these can be visualized and can be adequately addressed. So, and you can also know whether the wound gape is there or not, and whether your wound is complete, and that helps you to titrate your wound hydration. So you can see there's a small DMD which is present here, otherwise will not be visible, but this can be then addressed by just putting a bubble and seeing that this closes. Then again, there can be different situations like the posterior subcapsular cataract. You can actually make out whether the gap is there or not, whether it's posterior polar or actually posterior subcapsular cataract. It is very much intact. So it is a posterior subcapsular cataract. Here, this looks more like a posterior polar cataract. In white cataracts, you can see the fluid clefts. So once these fluid clefts are there, you know that the whole of the cortical matter is not going to come out like a blob, and then the rhexis can be done on this, of course, taking care that it doesn't extend. And this has been wonderfully shown by Dr. Rohit Om Prakash as well as by Dr. Gaurav Luthra. Now, suppose you have a white cataract which has a raised intraocular pressure such as this. It's absolutely, there are no fluid clefts present. And then, you know, in these cases, when it is like this, that when you give a nick, there'll be a blob of fluid which will come out. And so when there are no fluid clefts present, then this can be expected in such cases. Now, this is a case of capsular distension syndrome, myopia present postoperatively. This is because of phimosis, small capsule. So once this phimotic part is removed, then viscoelastic is aspirated. Notice how the lens is now just abutting the posterior capsule. So you know for sure that all the viscoelastic has been removed. So this helps you to titrate your steps. Sometimes the capsule even becomes crinkly, especially if there is a disparity between the IOL size and the size of the bag. Now, this is just to show the posterior subcapsular cataract. It may look like a polar, but it is actually not a polar, because you can see that this is a pseudo PCR. There is a PC intact which is present, which can be visualized here as well as here, and the cortical matter which is present above it. Now, this is a true posterior polar cataract because there's a gap which is present there on the intraop OCT microscope. So you can expect that this is going to open up during the surgery as you do, because there is this black area which is present, which is a gap there. So again, this acts like a third eye, and this was a child with a posterior polar cataract in which the surgery was done. The anterior capsular excis was done, followed by the hydro delineation, and again the disassembly of the cortical matter is seen. And in this, there was an open part which was there, which was highlighted as the surgery goes on. So layer by layer aspiration was done in the posterior polar cataract, as has been classically described. So except for the disc which is present in the center, the entire thing is taken off as is conventionally recommended for these cases. And as we come to the posterior plaque, it's kind of opened up. So you put a blob of viscoelastic there, heal on, and then this goes down, and this can be very nicely highlighted on the intraop OCT microscope also. Then a posterior capsular excis is done with the help of the forceps. Anterior vitrectomy is then done, and then intraocular lens is placed. And this, you can see that this is the anterior capsular rim, and this is the posterior capsule. So wherever this cross section will be, this red and green cross section, it is actually showing you that particular area. So you know where you are actually focusing. This is 3-piece lens which is being placed here, and after placing the 3-piece lens, the lens is captured, and as the spindle is formed, you can actually see the taut anterior capsule edges as well as the posterior capsule as the spindle of the optic capture is formed on the intraop OCT microscope. Now, this is again a very hazy cornea, and there's a Descemet's membrane detachment after keratoplasty. Now, if you didn't have the IOCT, you wouldn't know where to inject the air bubble. So you injected the air bubble, but this is still not getting opposed to the overlying stromal layers. So you have to do some drainage from the anterior side because there's a fluid which is still present. So as you give the drainage incisions, the fluid comes out and some gap decreases, and then subsequently when you put the air bubble, it's pretty much attached. So if you didn't have this, you would probably think that it is done, but it is not done until both the steps are taken. So this is to conclude that it is a very useful tool to have. Of course, the limitation is that it is expensive, but I'm sure with advancing techniques and technology, the companies are going to come out with the cheaper options. So thank you very much for your kind attention.
I think that was a wonderful presentation, Dr. Namrata, and in special situations, it would really come out to be.
I think we are short of time, so we don't have anything to do.
Yeah.
I think we are short of time, and we don't have much time for question and answers. So can we have the last speaker? And we also have in our webinar Professor Javadi. He is a very well-known ophthalmologist in Iran. He is the mentor of many famous ophthalmologists, and he has a lot of publications. And I am sure he had some comments. Of course, I'm not sure, but I know that he is very humble. He has a very knowledge, but he didn't say anything. I invite him at the end if he has any words or any comments we can hear. So I think we have better continue with the next speaker, and after that, if we will ask Dr. Javadi and Dr. Karimian if they have to say some words or any comments. Thank you very much. So the next speaker is Dr. Zari Ghanawati. He is an associate professor of ophthalmology at Mashhad Khorasan Medical Science, University of Medical Science. Can you, Dr. Zari, can you start your presentation, please?
Yes. Hello, everybody. I would like to appreciate our Indian colleagues for this great meeting. Could I ask the technical team to run my video? All right. This is my video. It's a very simple technique to stabilize the capsular bag and pupil dilation with the Malyugin ring. Okay, it's a routine case, but with the pseudo exfoliation and zonular weakness. We start from the incisions, and then we try to open the pupil. If you look here, you could see that I'm trying to show you that the zonula is very weak. When I touch the bag, it's moving a lot. And then I use the Malugin ring. It is 6-point quarter, and I put it inside in a regular fashion. I engage the proximal scroll, and then I try to engage two side scrolls. And if you could engage both of them, it's very good. If you couldn't, you could easily manipulate the scroll with the Sinskey hook. Here, I try to engage the other scroll after injecting viscoelastic. All right, I use the Y hook to do it. And when you engage all the scroll now, you start doing the capsular exis. It is very important to do the capsular exis inside the pupil margin. This case doesn't need a trypan blue, but because I wanted to capture the video, I try to stain the anterior capsule, and then I start to do a capsular exis just inside the pupil margin, and not bigger and not smaller, because then I have to do engagement with this capsular exis. Okay, I remove the anterior capsule, then I release two of the side scroll. I release them and then I engage them. When I engage them, I try to engage both the anterior capsule and pupil. Therefore, in two areas, I fixate the anterior capsule to the iris. And it's like you could see it here. I try to show you with the Y hook. Therefore, you actually fixate the capsular bag and the nucleus to the iris. You could engage all the four scroll, but I think two is enough. Two are enough. And then I do the hydrodissection and hydrodelineation. You have to do it in several points because it's a case with the hard nucleus and also the weak capsule, weak zonula. Then if you look at here, I'm trying to do a sculpting. There is no movement. Actually, you think that it's a normal case. You could continue easily without any fear of zonular dehiscence. And then I crack the nucleus. Look, there is no movement. But at the first, when I show you, there was a lot of capsular bag movement. And because now you have a fixation of the capsule with 2 points, there is no movement and you could do it very easily. I have been using this technique for several years, actually. At first, I tried to engage all the scroll. Now I do it just with 2 scroll. And remember, you could use the capsular tension ring as soon as necessary and as long as possible. In this case, because I think that it's not necessary in this point, I mean, when I managing the segment, I try to postpone it as much as possible, because you know, when you put the capsular tension ring, you couldn't easily remove the materials, I mean cortical materials. Okay, now I'm removing the last segment, and then again, because there is no capsular, I mean zonular weakness, I try to postpone the CTR at the end, but you could do it anytime you think that is necessary. All right, if you look at the capsular behavior, you could understand that the capsule is really fixated to the iris, and you could continue in a normal fashion. But remember, after you removing the Malugin ring, you will have a weak zonula. Therefore, you have to put the CTR at the end, or maybe in the middle of the surgery. Okay, I inject a viscoelastic, and then if you look at the anterior capsule, you could see the fixation point. Then I put the CTR, and at the end, I inject the lens inside. And then you try to release the scroll from the iris and the capsule, and you remove the Malyugin ring, similar to routine cases. And at the end, if you look at the capsule is completely intact, and there is no fear of the capsular rupture. That was my technique. I think I'm done. Thank you.
Thank you very much, Dr. Zari. Because we don't have any time for discussion, there is another webinar that is going to start, and we are really, we spend more time. So I would like to thank you, everybody, for the participation, and hope to see you all in person.
Thank you.
Sorry that we couldn't have the comments of Professor Javadi. I don't know if you have time to hear from Dr. Javadi or not. Do we have time, Mr. Rezai, to hear from Dr. Javadi some words? Or Professor Javadi, do you have any words to say?
Thank you very much, Doctor. Because the time is over, I only wanted to mention 3 sentences. One, in cases with mature cataract that anterior capsule extends, for the inexperienced surgeon, my suggestion is to convert to the extracapsular cataract extraction. And in those cases with subluxated IOL with capsular bag, my suggestion is to remove the IOL and the capsular bag by large incision from the anterior approach, and insertion of the IOL, AC iris fixated IOLs. And for cases with too much irregular cornea after RK, my suggestion is penetrating keratoplasty is less expensive in our country, and the quality of vision is better than those cases with toric IOLs. Thank you very much.